What they used is also pretty similar. There are not that many differences. If you do a study together, probably they will be pretty much the same. The diagnostic accuracy studies, they used a different criteria, and we used in ASIPP guidelines a different criteria. This was a simulation of multiple guidelines. Randomized trials are also pretty simple. Actually, they used the Cochrane, we used the Cochrane, but we used a different version of it, I guess. It will come back to the same thing, actually. If you look at it, there won't be that much difference. The evidence, analysis of evidence, they used this at least two consistent higher quality RCTs, or studies of diagnostic test accuracy. So we just need to stick to the definition. It says two higher quality RCTs. Then the same thing goes for the FAIR. You just want to look at the whole philosophy I have is that you just have to stick to the definition. Whatever you use as your inclusion criteria, just follow through it. This is what David Eddy showed us when we were listening to his lecture. This is the quality of evidence he was showing in his lecture, and this is what we use in ASIPP guidelines. And it does have observational studies. Accountability, conflict of interest, prioritizing the literature, peer review of evidence synthesis and recommendations, updating the recommendations, consistency with current literature. So sources of funding and grants. There are lots of questions here. I guess some of them may have been answered. He said it was only APS, so I didn't know if ACP had any funding or AHRQ, and who employed what the role of AAPM was. And there are two members. Again, I don't understand the status of them. Dr. Boswell and Lubna were on there, and they withdrew. What their status was, I don't know. But this was not reported in the public reports. So. There was an article by Paul Shekel. He's one of the authors. He wrote for National Guideline Clearinghouse. That is also AHRQ website. Well, he's an author. He writes a commentary on the guidelines. He provides the expert commentary. And in the disclaimer itself, he shows that he got paid for writing that. And he's also co-chair of the editorial board. So at least perception is that there could be a lot of conflicts of interest. He shows these guidelines are stronger on emphasizing need for psychosocial assessment compared to the AHCPR guidelines, which actually was a death sentence to AHCPR, is more forceful about imaging, is broader in the number of pharmacologic and non-pharmacologic treatment, and negative interventional technique opinions stay pretty much the same. Dr. Chow is the primary author. As I said, he does not accept new patients. So he does treat the patients, does not accept new patients. Probably he can answer us this. I was going to ask him, I forgot. But if his AHRQ, working for AHRQ or evidence-based center, is it not considered as an employee of the government? I don't know. The main second author for APS guidelines is Lori Hoffman. She's a psychologist, I believe. But she left the center in 2007 or so, according to Google search. There are other authors. Dr. Rosenquist, again, he is the primary author of ASA guidelines in chronic pain. Stephen Atlas, Stephen Stanos. Conflicts of interest. Institute of Medicine has published substantial information on this. He's part of that. Probably he will be writing some of those things. In New Yorker magazine in 2002 said, each approach to the diagnosis and treatment of back pain is a franchise designed to make money, not benefit patients. Spine surgeons chose their specialties for lucrative reimbursement. Mutually beneficial entanglements among spines. This is public perception about us. Well, Surgeon General Everett Koop said, I have never been bought, I cannot be bought, I'm an icon, and I have reputation for honesty and integrity. Guess what? 14 hospitals paid $40,000 each in exchange for being listed as the most innovative and advanced healthcare institutions across the country. How is that for conflict of interest? This is the letter we received last year before our annual meeting. I don't even remember what company is, but they listed Dr. Karaji as their advisor. So on accountability of EBM, there is a major article written about deconstructing the evidence-based discourse in health sciences. You can read it if you have time. I don't think I have time to go through that. But they discuss about the truth, power, and fascism. They call evidence-based medicine essentially fascism. Prioritizing the literature, was the search complete? Exclusion of the appropriate studies, inclusion of inappropriate studies. And he said 40 people reviewed their manuscript, the articles. So did 40 people review the entire document, or 40 people review different chapters? So that is the difference. But I didn't find much difference between the original document and the later on published articles. The incomplete literature search, no updates started yet, and will be at least 5 years based on previous experience, so we will be outdated by that time. Independence, evidence review process, voting process, communication. Diagnostic interventions, we keep talking about gold standard, gold standard. Gold standard does not have to be always a biopsy. It can be a long-term follow-up, but with the right modality of treatment. You can't follow provocation discography with a fusion, which has been shown to be a failure. But you can follow a facet joint nerve block with radiofrequency neurotomy or medial branch blocks or something like that. Reliability, validity. Provocation discography, as he showed you, they said there was no value for that. But they also utilized AHCPR guidelines, which has been updated. If you go to their website and says that not for patient use, not for clinical use. We did the systematic review, and Dr. Wolfer also did systematic review on the false positives. They found that the false positive rate was 9.3% when they looked at all the studies, not 100% or 70%. So these are all the studies they have utilized. It is, if you can't see that, maybe you need to see an optometrist, maybe not. It is a very busy slide, but it lists all the slides and all the studies, what studies were utilized by Chow et al. And what were not utilized. There is a second page to this. So they missed several of the studies utilized. There were 19 studies with controlled part and 5 with a controlled disc. They used 7 studies. 2 studies used other data. They were not original studies, but they were the analysis of other data. They also commented that we did a study, somatization, I think that is the one they included. We did 2 studies, but they included 1 study. In that, they said it was highly selective because we ruled out that patients did not have any facet joint pain before we did the discography. So that became a disadvantage. Actually, I think it is a great advantage that you ruled out the facet joint pain, then you are going for that one. Systematic reviews. Also, there are lots of differences in the way it was done. My friend Steve Cohen is here. They used that as a systematic review. That was a narrative review, so obviously that doesn't count much. Buenaventura, actually, according to they said 3 to 7. I see 9 items there, so I was thinking that it will be 5 of 9, which will be more than half. But when we redid it, when we looked at it, it was 7 of 9. Wolfer, it was not included in their study. They had very good rating there. Manchikanti et al. Had pretty good rating, less than Wolfer. Wolfer had the almost perfect rating or perfect rating. Wolfer did, Rick Derby and Wolfer did this false positive rate analysis. This is how they constructed a huge table and came up with the solutions. It was total was 9.3%, 0% in pain-free group, 3% if they had confounding factors, 10% low pressure or chemical disc. In a patient with iliac crest graft, 12.5%, 15% in post-discectomy. Diagnostic facet joint nerve blocks, they utilized this one study by Berkmeyer, which was very, very poorly done, and said there is nothing to prove that diagnostic facet joint nerve blocks are worth anything. So Datta is sitting right there, did this systematic review with controlled diagnostic blocks with 80% relief and ability to perform previously painful movements, and reached a different conclusion. These are all the studies, but none of these were utilized in their studies. So in this included studies, there was 1,420 patients were included, and average prevalence was 31%. Sacroiliac joint blocks, we do know that there is not that much significant evidence, and it is pretty weak. This is the diagnostic. But there is some prevalence of that. The arguments there could be that when the Laxmaiah et al. Did, they didn't have any false positive rate. So that kind of raises some questions. On therapeutic interventions, I think major confusion I still can't get over or understand this is the randomized study design. We call it randomized, then we get into where it should be performed, how it should be performed. It should be placebo-controlled, randomized, double-blind, so on and so forth, multi-center and all those things. But the definition does not say that. So if you want to say that, you should say that in the beginning itself. If you have a placebo-controlled trial, leave alone your sample size and all those things, of course, they all have to match. But what all it does is it measures the absolute effect size and shows the existence of effect. Something is working. If you do an active control design, that is a local anesthetic versus local anesthetic plus steroid or something like that, it does show that there is existence of effect. It is not saying that it doesn't work. There is existence of effect. And then it compares the therapies, two treatments. So you have two positive here, two positive here. As far as I'm concerned, they're pretty equal.